All right, good to see you.
Oh, great.
Well, I guess we're being recorded. You okay being recorded?
Sure, that's fine.
Up to you if you like to make changes. But great, if you want to do a quick A/B test, you got any slides to share? Let's just make sure it all looks the way it should look.
Great. Let me see if this works.
So it's just me, by the way. All right.
How's the volume in here? Is it a little loud?
I can control
you
if there's an
can.
issue.
Awesome, thank you.
Are you guys seeing the slides okay?
Looks pretty good. Do you have any video or audio or anything fancy?
No, nothing so fancy.
Okay.
Good old-fashioned PowerPoint.
Good old fashioned. All right. I think we're in pretty good shape then. We're gonna do a last minute bathroom run or get a water or something. Now will be the time to do it. People start trickling in, they're grabbing their food, they're sitting down. So we probably won't really like formally start until maybe closer to 4 or 5 minutes after the hour. But then in the intervening time, once we hit the hour or maybe a minute after, I might start just chatting with you at first. Dr. Weissman, so good to meet you. Tell us more about yourself. And you just kind of like getting to know the speaker for a few minutes and just it gives people time to file in and log in and everything.
Yeah, sure. That sounds great. Yeah, I'm really so glad to be here, and thank you for the invitation. I'd love to chat with you or whoever else is wandering in and out of the room too. My presentation style is usually more sort of chatty and interactive, but I know that's hard sometimes with a virtual platform. So anybody who wants to jump in, chat, ask questions, anything like that, it's great with me.
Great. I'll be watching online chat. I'll watch the room. Everybody wants to interject. I'll unmute the room so we can just hop in as we go. But you're right. There's the Zoom format. It tends to just inhibit people, even if they have questions. They just tend not to interject as much. But we'll get as much. If not them, I'll just interrupt you every 5 minutes.
Good. Oh, that sounds great. Yeah, I appreciate you have the video up here of the room, so at least I can see that there are real human beings on the other side.
I know sometimes you feel like you're just talking to this black void. Like, is anybody there? Am I talking to anyone? Oh, no. It's very, I know, it's very discouraging. We're just talking to a monitor. You can't even tell anybody's listening.
Yeah, talking to people is much more fun than talking to my computer, even in the age of AI.
FYI, for what it's worth, I'm actually going to visit UPenn. I'm going to give a guest talk there at one of the divisions. I will be there, I think on the 17th, April 17th. Really? So if there's some chance to run into you there, that would be nice.
Yeah, I would love to chat. Let me see, April 17th. What, which group or which seminar series are you speaking at?
It's Marilyn Ritchie's. What department is she in?
Oh, she's the division chief for informatics, although she does a lot of things too, so it could be related to something else.
And then Doxun Kim, I think, was the one who wrangled this.
Oh, okay.
Let me see. I think chaotic Kendall, but just I will be in Philadelphia for like a day, and it would be great to catch up.
Oh, great! Yeah, I'm on our critical care outreach and procedure service that day, which means I run all over the hospital, going to codes and rapid responses.
Nice.
So I will try to pop out, but if there's a chance in between, even just to say hi or grab a quick coffee or something, I'd love to.
What it's worth, I think I will be there one of the evenings. Maybe we can merge a dinner or something on 16th. I don't know. Anyhow, if we can, it'd be great to see it. I think there's a lot of stuff we'd have fun chatting about. So
yeah, for sure. I'd love to connect. That sounds great. I'll email Marilyn too and see if there's a way to officially get on your calendar.
Yeah, let me just forward you one of these email threads, and they appear to be from, I don't know, Director of Center for AI Translational Informatics.
It's really relevant to me.
I don't know which sub-organization it is, but this is how I made a connection at one of our conferences.
Great. Yeah, there are so many AI-related centers these days. Yeah. I can't even keep track of all of them.
Everyone's got to wait, no, I own a healthcare AI. What are you talking about? I own healthcare. Like, there's at least 10 groups at Stanford as well who claim that they are the healthcare AI center.
Oh, I thought I owned healthcare AI. All right, good to know.
It's all a marketing buzzword anyway, it doesn't mean anything.
They were like in the process of getting the data.
All right, people are starting to file in.
Yeah.
Just make sure we're situated.
Is the data and
Perelman?
yeah, we can ask them.
Like,
Everyone's grabbing their lunch,
variables that we're
so let's
using,
give them a minute and then I'll start the informal part of this moment.
like data quality stuff. But for now, we just choose like Dutch, like hospital data from the Netherlands and Belgium. That's quite similar, so, but I'm curious to see what it's looking like. Like from Denmark, Spain.
Yeah, and other than that, someone should go to study for a month.
Hi, David.
I'd like to know more about what I did. Things got improved and then we wanted to shift it to another hospital, but kind of problem was data.
Yeah, 1 month.
Do they have the same protocol?
Yeah.
All right, thanks to those who are starting to log in and file in. I can see they're still coming in. For one, you actually can't see, there's only half the room on the video. There's a whole other half of the room where there are more people, you just can't see them. As we were following before we formally get started, I'm very glad to have Dr. Weissman joining with us. Who I don't think I ever met you in person, but I read your work basically. There's a piece on like game playing AI systems or chess moves. Then you had another piece on Medicare risk adjustments using better tools. It's like, wow, this is like really good writing, very good thinking. I need to get connected with this guy, and we need to chat more. I think we really learn a lot from each other. But before we dive too deep into the topics, I think you're going to tell us about, can you tell us just a little bit more just about yourself? You know, where did you grow up? Where were you born? How'd you end up working in this crazy field? You didn't have to, right?
Oh, sure. That sounds fun. Yeah, thanks so much for having me. Likewise, Dr. Chen, I'm a big fan of your work. I'll talk about some of it today, although some also unrelated to the talk today. So really great to connect, and I'd love to chat more. So I'm a pulmonary critical care doc. I work at Penn. I spend most of my time in the medical ICU. And I do research on sort of clinical AI things, which is sort of how I ended up here, but took a long and winding road. I grew up around Philadelphia, was a physics major as an undergraduate, sort of pivoted at first to economics, and then realized that after spending a year in a little village in El Salvador, realized I wanted to do medicine, but still liked the nerdy quantitative stuff. So found my way into initially health services research, doing social network analysis methods for healthcare. And then in the late 2010, mid 2010s, when I was a resident and fellow, I was lucky that I already sort of knew R from a prior project. And then, all the new fun machine learning projects and libraries were coming out. So sort of found my way into clinical AI and ML. And initially just thought I was going to build prediction models, but the more time I spent trying to think about that, the more it became apparent that to do that well and make it effective is not so straightforward as a big data set and the new fanciest XGBoost package. So then in turn became interested in policy and regulation and human factors and some sort of adjacent topics, which is kind of how I got stuck into here now. So I live now out in the suburbs of Philly with my wife and 3 kids. I'm working from home today, but when I'm not at the computer, I'm usually in the garage building things out of wood. Currently making a laser shoot box for my daughter's Science Olympiad team, which has been really fun. Yeah, just really a pleasure to be here. And you'll see I'm talking about a range of topics, clinical medicine kind of thing. For the clinicians in the room, bear with me. For the data scientists in the room, bear with me. I'm hopefully going to bring it all together. But really welcome your comments, questions, feedback along the way, and excited to talk with you guys today.
Fantastic. It's quite, I don't know, was it a circuitous route or was there any kind of plan or intention from physics to economics to health services to critical care doctor. I mean, that's quite the range of skills, experience, let alone woodworking. I don't know, because a lot of the people in the room and online are training basically, right? You know, postdocs, graduates, they're trying to decide what to do with their life. Should they go to medical school too, or no? The answer's probably no. But I mean, how do you make these life decisions?
How do you make life decisions? That is I did not prepare that talk for today, unfortunately. But that's a great question. If I had to sum it up in 30 seconds, I would say I've always been a sort of nerdy quantitative type. And so that explains the transition from physics to econ to health services and informatics. But over the years, wanted to do something that felt more sort of applied. And realized I didn't just want to be like a cosmologist and sit in the room and think about black holes all day, even though it's fun, wanted to do something more real world. I actually did a primary care internal medicine residency, thought I was going to be a primary care doctor, but then did my intern year rotation in the medical ICU and just really loved the complexity, the relationships, which were actually quite similar to the primary care setting. But also really appreciated the end of life conversations and what that meant sort of on a personal level. I'm not going to talk about that today, but if anybody's interested, happy to talk about it more offline another time. The ICU is a pretty special place to work, clinically, intellectually, but also on a personal level. You see stuff that doesn't happen a lot of other places. So that's sort of how I found my way into it. But maybe to make it relevant to this talk, there's a great paper by, I think, John Kleinberg, who's a computer scientist at Cornell from many years ago, where he talked about sort of global versus local information in identifying shortest paths on a network. And I'm not going to do the whole paper justice, but one of the findings was essentially that you can do a pretty good job finding your way across a network just by using local information. And if I had to translate that into career advice, it would be, don't plan out your life from beginning to end too early, because you don't know what you're going to find. But if you look around where you are and you get to know yourself and know who you are and really what you're supposed to do in life, using that kind of local information will guide you to where you need to go.
Fantastic. All right. I mean, there's a lot more we can and should follow up on this thread, but let's go ahead and dive in and your core presentation. I'm sure we'll have a lot more discussion to follow and along the way. Take it away, Dr.
All right. Well, thank you for the nice introduction and setup. That was probably more philosophical than I planned to start with, but here we go. So I'm going to talk. Let me see if I can advance my slide. There we go. So I don't have any conflicts to report. I'm going to start off with a brief story. As I was saying a few minutes ago, when I was a resident and a fellow, I worked with a data scientist in our health system who, on the left, his philosophy was, we've got access to the data, let's just predict all the things. And he used to send this meme around all the time. I think he even made a t-shirt at some point with this thing. This was the philosophy maybe 10 or 15 years ago for clinical AI, just predict all the things. At the same time, on the right, what you see is a plain radiograph of the chest of a patient who has what's called ARDS. And for the non-clinicians, that's a very severe form of respiratory failure. And there are particular criteria that define who has ARDS and who doesn't. And I recall very distinctly as a fellow, one of the world experts, leaders in ARDS, came to our division and gave this talk and said, you know, the truth is, at the international meetings, when all the experts get into the room together and we look at the chest x-rays, we actually can't even agree among ourselves who has ARDS and who doesn't. And I think he quoted the agreement as somewhere around 50%. Which was really hard to hear, because here we were training all these prediction models, and yet the clinical outcomes, especially in critical care, although relevant in many other fields, there's so much in medicine that we actually really don't know, we don't understand. So if a clinician tells you this patient has ARDS, they might, but if a world expert walked in the room, or 2 or 3 world experts walked in the room, they might actually disagree. So this is really the focus of what I want to talk about today, which is how we think about training labels in critical care in particular for these syndromes where we really don't know what the thing is. And we'll talk about how this is relevant for AI and other domains too. All right, so just a brief overview of what critical care is for the non-clinicians. As I said, it's a very meaningful field to work in, highly recommend. We take care of patients who are very severely ill, often have life-threatening injuries, and the kinds of clinical syndromes that we see are things like sepsis, shock, cardiac arrest, respiratory failure, and patients who need immediate care. So because of what critical care really is, these patients need immediate attention. They have lots of data sources, ventilator waveforms, arterial waveforms. They get labs and vitals checked very frequently. We're often making treatment decisions without actually knowing what the diagnosis is. And as I alluded to also, we spend a lot of time talking with patients and families about prognosis, which is critical for the communication and decision-making side, but clinicians aren't actually very good at it. And so all these things taken together would make you think, oh, critical care is the perfect place where machine learning and AI type tools might be helpful. That being said, we haven't really gotten there yet. So this is a wonderful review from a few years ago. It's now a little bit out of date, although I think qualitatively the results are really the same, where the authors reviewed a whole bunch of machine learning, prediction modeling type papers in the critical care space. And they broke them down into categories according to NASA's, what they call the technology readiness level. And I don't know, I'm going to try to use my mouse pointer here. If you can see, about 93% of the published papers were in this model prototyping and model development stage. And I would say as a reviewer, this rings true with what I see too. Only 1% of the papers ever made it to the clinical outcome evaluation stage, and 0% of the published papers ever made it to this model integration stage, which is the most sophisticated or mature stage of technology readiness. So pardon the poor pun, but in critical care, even though there's great alignment between methods and needs, none of these systems are really ready for proverbial takeoff. And so I want to spend time today mostly talking about why they're not ready so that we can try and overcome those barriers. I often get asked when I give talks like this, well, all you're doing is saying why AI doesn't work. What's an example of a system where AI really does work well? So I don't want to come off as a naysayer because I work in this field and I'm optimistic about it. But I want to put up this slide just briefly. If anybody's looking for a great example of a randomized clinical trial of a predictive AI system, this is really a wonderful one. The accompanying editorial here was by Derek Angus, where he described this as sort of a phase 2B drug trial equivalent. And there are just lots of wonderful things about both the predictive model development, about the clinical decision support interface, and about the study design that I think are worth looking at if you're interested in RCTs of AI systems and especially critical care related AI clinical decision support. So I just wanted to throw this up there as an example worth reviewing. All right, so because we're talking about critical care, I'm going to spend most of the time focused on sepsis, which is really a paradigmatic critical care syndrome for many reasons. And sepsis is so popular that a few years ago, the PhysioNet group even held a prediction of sepsis challenge. There are so many sepsis predictive modeling papers. I think I can only see about half of the room, but I would ask you, if you don't mind, raise your hand if you've ever been involved in a sepsis prediction modeling paper. Yeah, I have. I see a couple hands up, Yeah, everybody and their grandmother who does clinical AI has been involved in a sepsis prediction modeling paper. But like many of the published papers that were mentioned in the Florin study, very few of them have actually made it to prospective testing, and even fewer in clinical trials. So what I'm going to posit here is that one of the reasons why it's so hard to build a meaningful sepsis prediction model is not at all related to AI methods. It's actually related to inherent clinical uncertainty and ontologic challenges and actually what we think sepsis is. So on this one, you can just blame the doctors and blame the basic science researchers because we just haven't figured it out yet. So the concept of sepsis has been around for a very long time. The most recent construction of sepsis was published in 2016. This is called this, excuse me, the sepsis-3 definition. And the stated purpose of the sepsis-3 definition was to offer, here I'm quoting on the right, greater consistency for epidemiologic studies and clinical trials, because we really needed that to make sure that we were standardizing enrollment of patients in clinical trials. It was really important for epidemiologic surveillance and quality report measuring. And then sort of the third purpose of this was to facilitate earlier recognition and more timely management, which for people building sepsis early warning systems or prediction models, that's the part that we care about. So we do know a lot about sepsis at the basic science level. I'm not going to get into this slide in detail, but this is a great review if you're interested. And essentially what it says is that sepsis is a dysregulation of the host immune response, meaning the anti-inflammatory response is out of whack as well as the inflammatory response. And that imbalance or that dysregulation is what leads to end organ dysfunction, which is now the core defining characteristic of sepsis-3. What's important about this slide, though, is that even with all of the pathways and the soluble mediators and other biochemical processes that we've elucidated related to sepsis, we don't have a definition of when sepsis begins based on these biochemical markers. Similarly, we don't have a definition of when to initiate treatment with antibiotics, which is the mainstay of therapy, based on these biochemical markers. The current definition, sepsis-3, is based on observed organ dysfunction and a clinician's suspicion of infection. So that's important when we're going to talk about training labels. So this is also important because, as I said, time to treatment with antibiotics is really the mainstay of therapy. And depending on which study you look at, delays of even an hour or a few hours can lead to substantial increases in mortality. And so recognition of sepsis is very important. Recognition and treatment are also impaired by usual hospital processes. This was a study from our hospital led by Dr. Jen Ginestra, who's now at University of Colorado, and Dr. Rachel Cohn, who's at Penn, where they looked at what happens to the delays in sepsis when a hospital ward gets very busy. And what they found is that as the ward gets busier than it usually is, the time to treatment with broad spectrum antimicrobials increases. And you see here at the top, the orange line, this is based on the sepsis-3 definition. They did a secondary analysis also looking at the CDC adult sepsis event criteria definition. And this is sort of like a modified version of sepsis-3, but it's another example of a sepsis definition that was originally intended really for quality reporting and surveillance purposes. But both of these definitions end up getting used quite frequently for training labels for clinical prediction models. So in a follow-up study to that one, Dr. Ginestra and Dr. Cohn also looked at temporal variation in the time to antibiotics by shift. So on the y-axis, you'll see the probability of antimicrobial initiation at any given hour of the day, which is here on the x-axis. You can see this is the day shift on the left, the night shift on the right, and shift change happens here at 7 p.m. And here at 7 a.m. Oops, sorry about that. So what's notable about this is that unrelated to any physiologic things, delays in antibiotics are much more significant at shift change in the morning and in the evening, and much more significant at nighttime compared to daytime. So there are hospital processes related to handoff, staffing models, decision fatigue, other things that we might hypothesize contribute to this variation, suggesting the face validity of some kind of AI-based clinical decision support tool, which would be really helpful to help reduce some of this variation. So I'm going to talk briefly about kind of how sepsis went here at Penn. So we've had 2 sepsis early warning systems in our health system over the past 10 years. The first one we called EWS 1.0, and it was a pretty simple rules-based algorithm. We used the SIRS criteria, which is actually an older sort of defining criterion of sepsis, and some organ dysfunction at a particular time. And the outcome that it predicted was a composite of death, transfer to the ICU, or a rapid response team activation, which is when an emergency team comes into the room of a patient who's getting sicker, sort of like calling 911, but within the hospital. Excuse me. And the positive predictive value for that model was 28%, which might not seem very high, but in the world of early warning systems is actually pretty good, meaning that close to a third of the predictions actually ended up becoming true. So that was the first round. I'll show you a couple slides in a minute about how clinicians responded to those alerts. And I can tell you that I was a resident at that time, and most of the residents would roll their eyes every time they got the page, because it meant that they had to go down, see the patient, have a meeting with the nurse, write a note, and we were still using paper notes back then. And so it was not welcome. That being said, Penn then stopped it, reintroduced what was called EWS 2.0. And this was a very complex machine learning model. It was a random forest model with hundreds of variables. The positive predictive value was roughly the same, but the outcome that it was predicting was this interesting choice of an administrative label definition, meaning a patient who at some point after their hospitalization was over acquired an ICD code associated with sepsis, as well as some changes in vital signs and organ dysfunction similar to like a SIRS criteria. This model also was not met with a lot of clinical fanfare. And so I'll show you, this was the follow-up study after sepsis 1.0, where the team went around and they asked physicians and nurses about the helpfulness of the alert. And I'll just draw your attention to, let's see, here, about half of the physicians thought the alert was well-timed. More than half of the nurses thought it was well-timed, but only a third of the physicians thought it was helpful. 40% of the nurses thought it was helpful, and 50% of physicians thought the alert did not improve care, and about a third of nurses thought that the alert did not improve care. So there's this problem of bedside relevance. When the alert would fire, even if it was sort of roughly on time for when things were going on, the alert didn't really tell the clinicians anything that was too helpful. This is a very similar follow-up study that was done after EWS 2.0. And here you can see in the left panel, we're looking at whether or not the alerts were unhelpful, neither, or helpful. 16% of physicians thought it was helpful, which I would argue is not very many. 42% of nurses at the time thought it was helpful, many more than the physicians. And in terms of care processes, only 11% of the physicians thought the alert improved care, while a third of the nurses did. So notably big discrepancies between the nurse and the physician responses, but overall not really very high in terms of thinking that these alerts were changing anything much at the bedside. All right, so this really got me thinking about what's going on with the training labels. What is it that we're predicting here? So our team conducted an electronic survey where we pulled out real cases of documented sepsis 3 from our health system, extracted the data into this presentation that you see here, and sent these vignettes to clinicians all over the country. We sent them to emergency medicine clinicians, to hospitalist clinicians, ICU clinicians, and infectious disease clinicians. And we said, looking at these charts, in retrospect, would you have started antibiotics? And if so, at what time? So we pulled, excuse me, 8 vignettes with sepsis. We also included a 9th control vignette where the patient definitely did not have sepsis and also had no organ dysfunction. We ended up with 153 respondents. In the control vignette, 97% did not suggest initiating antibiotics. And then when we looked at the responses on average, clinicians suggested starting antibiotics 7 hours before sepsis 3 onset occurred. And in the world of sepsis treatment, 7 hours is a very, very long time. Depending on which studies you look at, that could be associated with sort of 10 to 20% increase in mortality, just based on those antibiotic delays, suggesting that on average, sepsis 3 as a trigger for an early warning system is probably way too late. The other interesting thing, if you look at the panel here on the right, even though there was a 7-hour difference on average, there's actually tremendous heterogeneity among the vignettes. So here for vignette 4, the clinicians really had pretty good agreement and mostly suggested starting antibiotics around here, which was well before sepsis 3 onset occurred. But there were a couple of vignettes, like this orange one or the blue one, where there seemed to be pretty good consensus that starting antibiotics after sepsis 3 was probably the right choice. And here in this dark blue one, the groups were split. So I take this to mean that even though on average sepsis 3 is too late, there's tremendous among vignette heterogeneity, and that sepsis 3 is probably not a reliable marker to indicate that we should be starting antibiotics. We also looked at among specialty variation. Not surprisingly, the emergency medicine clinicians, this is a cumulative incidence plot, were more likely to initiate antibiotics and more likely to initiate it sooner. At the other end of the spectrum, the infectious disease clinicians were the least likely to initiate antibiotics and also were more likely to initiate much later compared to the other specialties. So there's probably something both about sort of base rate effects and where these clinicians train, their tolerance for risk and benefit, and also the particular criteria that they're adhering to. I won't talk about it too much today, but there's actually a bit of a controversy among different clinical specialties about how much time you have from when sepsis is recognized to when you should start antibiotics. So to summarize the sort of sepsis problems, this is in many ways, as I said, an ontologic challenge about what is sepsis, but also a human factors challenge in understanding what is going on with human decision-making when we get one of these alerts. So this is a really wonderful conceptual model from Hallie Prescott and Jack's experts. And so they created this nice heat plot here, where on the y-axis, you see the illness severity of a patient. Whoops, sorry. And on the x-axis, we have the likelihood of a bacterial infection. And I like the sort of vagueness of these different zones in the heat map. Qualitatively, I think they're very accurate. We do different things down here than we do up in this quadrant versus this quadrant. This red quadrant is sort of the hot spot. And up here in green, this is actually where the sickest and highest risk patients are, where the treatment is most clear, but we don't actually know how to quantify these different regions. And so far, sepsis prediction models have really not been trained to predict these things, which is much harder to acquire as a training label. Excuse me. All right, so keep that in mind. Let's put a pin in that about what's going on clinically with sepsis. Thank you for bearing with me with the clinical lesson. We're going to pivot some more to methods for a minute, and then hopefully tie it all together. So what's going on with reinforcement learning? By show of hands, anybody use reinforcement learning in their work? Anybody train a reinforcement learning model? I'm not seeing a lot of hands.
A couple,
Which,
but
to be
not
honest,
so much.
oh, okay, interesting. So I wonder then what your take will be on reinforcement learning. I'd be interested to hear your thoughts on any of these slides. So a few years ago, something very interesting happened in the world of sepsis. This paper was published where the authors claimed that they used a reinforcement learning strategy, and here they call it the artificial intelligence clinician was the RL model that was trained. It learned optimal treatment strategies for sepsis. And that's a huge claim, because if you follow the sepsis literature, if you're a critical care doc or an infectious disease doc, we're always trying to find optimal treatment strategies. So to claim that the AI clinician, a reinforcement learning model, learned that, that's a really, really big claim. So what the authors did was they took the MIMIC data set, which is a free, publicly available critical care data set out of a single hospital in Boston, and they trained the reinforcement learning model on that retrospective EHR data set. And what they found is that the model was able to, or they claimed that the model was able to figure out treatment policies that were better than what the clinicians had actually done in the data set and improve mortality. So that's a bold claim. I'll say there was a very nice accompanying editorial to this paper by Dr. Saria, where she highlights that reinforcement learning, as you guys probably already know, is usually used in the online setting. And here, online reinforcement learning refers to the more traditional RL models where you have a robot sort of interacting with the real world with the rules of gravity, or you have a chess playing AI system that's actually playing chess and learning as it goes. So what's different here, as Dr. Saria highlights, is that when you apply reinforcement learning to a retrospective data set, you have to correct for subtle biases that may be present. And there's an entire field of observational research and causal inference that's dedicated to dealing with the selection bias, the confounding by indication, and other important biases that affect causal inference claims when using retrospective observational data like this one. So reinforcement learning doesn't bypass all of those concerns of bias related to confounding and selection and other things like that. If you want a deeper dive, this was a really fun preprint, although it has sort of a snarky title, that really goes step by step through the claims in this Nature Medicine paper, tries to recreate their analyses and highlights a lot of the methodologic limitations associated with using reinforcement learning in this context. But I don't want to throw that paper out because I think there's a kernel of something really important in there. So this is just a nice review of what's often called offline reinforcement learning, which is in some ways really what the authors did. And I want to highlight this as an innovation, really, even if the central claim of the paper, most people, I think, probably disagree with today. So here on the far left is an example of what is traditionally called online reinforcement learning, or where the robot or the chess playing bot or whatever it is interacting online with a real system and learning policies in response to changes in that system from its policies. On the far right, though, is this idea of offline reinforcement learning, where some agent interacted with the real world once and we collected data about it, but now we're training a new model to learn those patterns retrospectively based on when those data were collected. And in the setting of healthcare, this is really interesting and innovative, but it's something a little bit different than what I think the authors were initially claiming, but still is very valuable. And I will say that this is a very nice review. And here Levine et al. Highlight that when we're doing offline reinforcement learning, you can certainly use traditional RL methods like Q-learning or whatever's your favorite RL approach, but that traditional supervised learning approaches also work just as well for this offline reinforcement learning that uses retrospectively collected data, which really reflects the scenario that we usually have in medicine, where we have large EHR-based data sets or claims data sets. So I want to pivot again for a minute and just highlight this, which I think is one of the most fun papers I've ever read. Strongly recommend taking a look. This emerged during the pandemic. Like many people, I was home too much, playing a lot of online chess, and for some reason found my way into reading archive papers about chess bots. So what the authors did was they realized that now, most computer playing chess systems like Stockfish or AlphaZero, they're in competition with each other, but they're not really in competition with human beings anymore. These systems crush humans easily. And so there was this need, ostensibly, to build chess playing AI systems that could play in a more human-like manner. Because these Stockfish and AlphaZero top machines, not only were they good, they were using totally new strategies and styles that human beings didn't really use or had thought of before. And so I guess for some people, it was less fun to play against. So this group out of the University of Toronto trained what they called the Maya bot, where they downloaded millions of chess games from the Chess website. And again, now this is akin to more like offline reinforcement learning. And they trained their models to predict not the best move, but the most likely move, conditional on the performance or the rating of the players that it was training on. So for example, here, this is Maya Chess 1100. This is the low level bot. For those who play chess, an 1100 rating is sort of like, you're not very good, but you're maybe like an average beginner or something like that. So you're okay, but you're not particularly good. So they trained the Maya 1 bot on games played between 1100 ranked players, but something really interesting came of this. And if you look right here, you can see the rating of this Maya bot. It actually performs at about a 1400 level rating, or even a little bit better, depending on what type of chess it's playing. And that's fascinating because it was only trained on games among 1100 ranked players. So why does it do so much better than the players that it was trained on? Excuse me. So to me, this was a fascinating finding, and really led me to think about how this translates into the world of clinical medicine. So human biology and physiology, we don't really have the rules for the same way that we have the rules for chess or Go, or the rules of gravity if we're training robots. So if you give a fluid bolus to a patient and the blood pressure gets better, or it gets worse, or it gets the same, we don't understand how that policy choice affected the state of the system in a retrospective data set. Even prospectively in real time, we don't. That's why we do clinical trials in medicine. Causal inference is very hard. But the use of retrospectively collected chess games really does mirror the kinds of data that we do have. And so we can still take advantage of that, even if we're not claiming that the AI clinician learned optimal treatment strategies. If we consider a different clinical decision support paradigm for offline reinforcement learning using these data, there still is something to be learned there. And what I would argue is that if we make the claim for an AI-based clinical decision support system, not that I have the right answer, or I have the right diagnosis or the right treatment, but I have not the most human chess move, but I have the most likely treatment or the most likely diagnosis based on what your peer clinicians would do in a similar circumstance, conditional on these patient characteristics. And that may still be an effective clinical decision support tool, but it's one that's actually feasible to build, to train, and it's potentially more interpretable and believable at the bedside, and parallels this approach of using collective intelligence imitation learning rather than trying to claim that we have a model predicting the right diagnosis or the right treatment, which in many cases we're never going to get to. So I don't want to throw out online reinforcement learning entirely in healthcare. Dr. Chen and colleagues wrote this really nice perspective piece where they highlight a role for online reinforcement learning in what you write in your piece very nicely is in-game randomization, meaning that there's, at least I interpreted it to mean, but please correct me if I'm wrong, that there's a role for online reinforcement learning, but it has to be done in the real world, meaning patients in real time could be randomized to different strategies that a reinforcement learning model could suggest. But we have to take care with that because there has to be a human in the loop. And it's also challenging to get there because our health systems and EHR infrastructures aren't really set up to do this kind of work. So I absolutely think there's a role for online reinforcement learning, but I don't think anybody's really done this yet. So maybe you guys will figure that out in a couple of years. Dr. Chen, is that a fair characterization of where you guys were going with this in your piece?
Yeah, I mean, a lot of the same things you're addressing, Cal, reinforcement, wow, so cool, all this AlphaGo stuff, it's like, wait a minute, you can't do that for medicine, because we don't have a proper simulation. And so maybe the closest thing we get to is kind of like pragmatic trials, embedded randomization, and people have done on micro targets some of that. I think we're seeing that more. I think that's a really compelling way we can learn as we go. Because there's plenty we do in medicine where we don't actually know, right? Where do you want to randomize or do you want to guess? And why do you feel better about somebody guessing?
Yeah, absolutely. Yeah, tremendous opportunities there. So I didn't want to discourage that idea entirely. I do think that there's a role. So let me pivot now to try and pull it together and talk about collective intelligence and imitation learning, which I think are promising strategies for AI clinical decision support. Does anybody know who this guy is? Show of hands. I can't see. All right, shout it out. If not, I'll just keep talking. What was that?
We're clueless. Don't know.
Clueless. All right. So I wouldn't expect you. I didn't know what he looked like, so don't feel bad. This is Francis Galton. So there's a funny story about him that you may have heard, where over 100 years ago, he was at, I guess, what was the equivalent of a county fair. And he asked hundreds of people at the fair to guess the final weight of a dressed ox. And I think he got close to 800 submissions. He tallied them all up on these index cards and he lined them all up and he identified the median guess of the final weight of the ox. I don't butcher oxes for a living, so I don't know the sort of details of how this works, but it turns out the final weight of the ox was over 1,000 kilograms. And the or is that no 1,000 pounds? I'm sorry, 1,000 pounds. And the final or the median guess of those hundreds of attendees was only off by something like 8 or 9 pounds, so a less than 1% error. So he remarked on this and he said, this result is, I think, more creditable to the trustworthiness of a democratic judgment than might have been expected. And so some people cite this sort of anecdotally as the beginning of this idea of collective intelligence, or what came to be called later sort of popularized by James Surecki's book, The Wisdom of the Crowds. It's a really cool idea, although I'd say it doesn't always hold up. On the right, that's Garry Kasparov, who several decades ago played a game of chess online against over 50,000 people who contributed to different moves. And in that case, Garry Kasparov actually won the match and he beat tens of thousands of people in chess, suggesting that maybe collective intelligence isn't always the strategy to beat geniuses like Garry Kasparov. So it might not apply in all circumstances, but I will say, I do think it's relevant in the world of diagnostic excellence, in part because if you look at Hardeep Singh's work on diagnostic error, especially in primary care, the most common diagnostic errors are actually just due to common diagnoses. It's stuff like heart failure, urinary tract infections, pneumonia, and not surprisingly, because rare diagnoses, not only are they rarely missed, but they're just, they rarely present. And so from an epidemiologic standpoint, we get more bang for our buck trying to correct the common errors just because they are by definition more common. And this idea that collective intelligence in the clinical world improves medical decisions is not a new one. It's not an original one. There's tons of evidence for this, and this could be a whole separate talk, but I think offers promising insight into how we think about selecting our training labels for clinical decision support systems. Here's a nice example of trying to apply this that's now almost 15 years old. In this study, the authors identified paired orders in hospitalized patients and tried to identify common pairings. And you can see on the left, if a patient, for example, had a hemoglobin A1C ordered, that's a screening and monitoring test for people with diabetes. It was quite common that they were also ordered a diabetic diet, meaning like a low carbohydrate diet to help with their diabetes. Similarly, here, this is a folate level. Folic acid deficiency is a very common cause of anemia, and it can lead to what's called a macrocytic anemia, and a B12 level is another vitamin deficiency that can lead to the same thing. So oftentimes, here they say for alcoholism, we wouldn't use that term today, but also for workup of anemia, we would, they noted that anytime a folic acid level was measured, a B12 level was also measured. So they use this to try and build clinical decision support in what they were calling like a recommender system to say, if we see you ordering this, we think you're also going to want to order this. And then they did a nice clinical validation here on the right, where they asked, I think it was hospitalist physicians, to review the recommendations ranked by their performance. And you can see the top ranking rules, for the most part, did pretty well. The lower ranking rules, not so much. So maybe based on their data set or maybe their modeling approach, there was some reasonable threshold to consider here before actually deploying these in practice, which I don't think they got to for this study, but certainly sounds promising. And then another exciting paper from Dr. Chen in your group, looking at people who were referred for endocrinology evaluations who had not yet seen a subspecialist. And one of the clinical challenges here is that many patients who are referred to see subspecialists don't come with the right workup before they get there. And in the pulmonary world where I work, that's very common, that patients get referred to see a pulmonologist, but they don't have imaging of their chest. They might not have pulmonary function tests done already. They might not, depending on what the suspected etiology is, have sputum cultures or serology testing or other things. And so it really decreases the efficiency of the evaluation and also often decreases the time to diagnosis and treatment. So here, the team created similarly a co-occurrence matrix of orders. Here it was informed also by patient characteristics, and then build a recommender system to say, based on these characteristics, we think this would be a relevant endocrine related test or other thing to order to help expedite this evaluation. And in the table below, what you see is that the recommender system on review had really good discrimination, had good positive predictive value compared to these other strategies for recommending tests. And all of this was just based on what was observed already in the electronic health record, really benefiting, I would argue, from a collective intelligence imitation learning type strategy. So to sum up a little bit, we have a couple of different interrelated problems related to training labels, not just for sepsis, but in a lot of other clinical domains where there's high uncertainty. And I think this strategy helps overcome some of those problems when building AI-based clinical decision support systems. So the first one is that oftentimes there's just no gold standard label for a particular disease. And the chest X-ray I showed in the beginning for ARDS, it's very hard to define ARDS, and experts often disagree. In which case, if we shift our clinical decision support paradigm from, yes, I'm predicting the right answer, to I'm predicting, well, I'm just predicting what your colleagues do as a sort of nudge to consider in your own decision making, that's going to be, I think, more effective and more believable. Even if you could acquire a gold standard, as you know, if you've ever done chart annotation or hired somebody to do chart annotation, very costly, very time consuming. But if we shift to this imitation learning approach and rely on the value and reliability of average judgments, the same way the Maya bot overperformed the players it was trained on, we benefit from all the data that's already in the EHR, bypassing the need for annotations. And then finally, stepping aside from this claim of the correct diagnosis to really a social norming strategy is really, again, a paradigm shift in clinical decision support. And in this case, what I'm talking about is what's called a descriptive norm rather than an injunctive norm. Injunctive norms are those where we say to people, this is what you should be doing based on the sort of norms of your profession or the norms of your descriptive norm, which is considered a more less judgmental behavioral economic nudge, is a way of saying, well, we're not going to say whether it's right or wrong, correct or not correct, but on average, this is what your peers would do in this situation. So we're really a very different approach to clinical decision support. There are some important threats to this approach. The biggest one being reinforcing bad behavior. So if all the clinicians in primary care, for example, are ordering MRIs for low back pain that's otherwise low risk, it's probably not a good use of resources, but the model will learn that and suggest that. So we have to think about that. This approach also won't account for outcomes that are very rare, and we won't see enough of a sample size to benefit from collective intelligence when making predictions. Also, outcomes that are never documented. So consider if you're in a community setting and you have a rare diagnosis that never gets made in your health system, but only gets made when the patient gets referred to a large tertiary referral center, that ICD code may never show up in your EHR. And so you'll never have that outcome to learn the label, and you'll continue to miss that diagnosis. Finally, with this paradigm, there's likely to be heterogeneous clinician response. So for AI systems in general, there's automation bias or over-reliance. There's also what some people call algorithm aversion bias, which is where the Luddites say, oh, I'm just going to do the opposite of whatever the AI says. Here, similarly, we don't know how clinicians will see heterogeneous personality traits and other things. I think I'm running out of time, I think. So I'm going to just zoom through the next couple of slides, and then I'd love to chat with you guys and take questions. I'm going to zip through this and just say we've started to apply this in the setting of ventilator management, in part because managing ventilators is a really complex and interrelated decision where there are multiple, depending on how you count, a dozen or even 24 simultaneous decisions that have to be made. So using this imitation learning collective intelligence approach allows us to build decision support systems where the output vector is large and complex. Similarly, we have a pilot grant from Penn AI Tech, which is funded by the NIA, to build a diagnostic decision support system in primary care, where again, the diagnostic scope is large. Primary care clinicians encounter thousands or even tens of thousands of different diagnoses. And so single disease predictive clinical decision support is really not aligned with the scope of diseases that they're seeing. And so here's just based on a preliminary model, calibration, predicting the most common diagnoses and also the most common orders, absent even having to make a diagnosis. So this approach works reasonably well in practice, and we have an upcoming pilot study to actually put this in a clinic. I'm going to zip through this. I was going to talk about FDA regulation, data, clinical AI. All right, so we really don't have enough randomized evidence that clinical AI systems in critical care or in general really produce better decisions or outcomes. In the setting of sepsis and critical care in particular, there are a lot of ontologic, epistemic, and human factors challenges really at the intersection of clinical medicine, of data science methods that really warrant close collaboration to try and solve. And we didn't talk about it too much, but I think one of the reasons is that we don't have good regulatory incentives to produce high quality clinical evidence for this work, but hopefully we get there in a couple of years. So with that, I'll just say thank you to all my team members, collaborators. Thanks so much for the chance to chat with you guys today, and would love to take any questions or hear any comments or feedback. Thanks for your attention.
All right, fantastic. Thank you so much, Dr. Weissman. Any questions from the room? Gil Bedran, looks like more of a maybe a comment or question on an earlier part of the Gil, you want to jump in?
Sure. Can you guys hear me?
Yes, go ahead.
Awesome. So thank you, Jonathan. This was related to the very first part of the talk. I was just surprised with the sepsis model. You were essentially trying to evaluate them by seeing what the clinicians thought of the system deployed, I guess, alongside them. I thought that, that would bring out the Luddites and the technology enthusiasts. I thought you tried to also maybe correlate it with outcomes in some way, or is that's not easy or possible with sepsis?
That's a good question. So at Penn, unfortunately, neither EWS 1.0 or 2.0 were rolled out with a randomized design. There were some outcome evaluations, but they were more pre-post designs, which especially for sepsis, which is, for anybody who works in a hospital knows it's a hot topic. There are always ongoing quality improvement sort of rollouts and BPAs and things that are happening, which really highlight the importance of a randomized design. The alerts at our hospital did increase ordering of lactic acid as a blood test. It increased transfers to the ICU and made them happen earlier, but there wasn't any detectable difference in in-hospital mortality or length of stay or anything like that.
Got it. Thank you.
Yeah, great question.
Just thinking back time for one of your first comments, a really funny meme thing. I might copy that. What was it? Let's just predict all the things. Why think about it? Just get the data and just predict everything. So I think you're kind of making a joke like that's kind of silly. You need to have more purposeful ways of thinking. But on the other hand, you actually just were touching on that last example in a general primary care or general clinical setting. Having one prediction model per disease is unusable because there's just too many things we have to consider. And you kind of do need this general purpose. Just what are all the range of recommendations I have to consider? Are those compatible thoughts? Are they in contention, or what are you thinking there?
That's a great question. I think it gets at the issue of the importance of having clinical domain experts at the table before it's worth really digging into a data set and building a prediction model. Because the opportunities for an AI-assisted decision will really vary a lot by the clinical setting, by the end user, by the risks and benefits, and by the stakes of those different decisions. So in the primary care setting, I do think a more sort of general approach makes sense, in part because, like you said, if you have one model for heart failure, one model for cancer, one model for rheumatoid arthritis or whatever, which is actually what most of the primary care CDSs do, there's no way you're going to get to build the 10,000 models necessarily to identify all the relevant diagnoses that are encountered. In the inpatient setting, though, sepsis is unbelievably common, and it affects medical patients, it affects surgical patients, it affects obstetric patients. It really affects everybody and is an enormous contributor to increased length of stay, in-hospital mortality, morbidity, and hospital costs. And so that's an example where a disease-specific model, I think, does have benefit, because if you can identify those patients better and earlier, then I think we will see improvements in patient outcomes. So I think that's just a matter of having the right clinical domain knowledge to guide the development of the appropriate system. So I don't see them as necessarily in conflict, more like a precision AI strategy for each particular clinical context or domain.
Maybe a comment more, some of the behavioral economic perspectives you're thinking of, I think are very compelling, and many of us are not trained in. But there's this aspect of, I've heard of this of injunctive versus descriptive terms kinds of things. If we make this super cool model, and it is measurably better than if you let a human guess on their own, still getting people to accept it is a huge gap. And I think we completely fail at 99.9% of the time. What are the lessons we should learn? How do we go from cool technology towards people can actually use this in the way they work?
That's a great question. So I didn't talk about it too much here, but I think the field of human factors is actually unbelievably important for the success of building AI clinical decision support systems. And I mean that both at sort of the final phase, where you're rolling something out and you make sure that your interface is readable and usable and well integrated with workflows. But I think good human factors work starts well before that. And it includes doing deep qualitative work, sometimes ethnographic work with the end users, whether those are the patients, the clinicians, the caregivers, or whomever, and understanding their informational needs and opportunities to alleviate uncertainty. I think it also looks like once you've done that work and before you roll out a model, make sure you have some kind of educational program or clinician engagement model that says, all right, you're all the doctors and nurses that work on hospital ward A. Let's make sure in our weekly huddle or whatever it is, we're doing some training. We have an educational video, we have resources. The same way when you roll out a new EHR, there's always hospitals have what they call them like EHR champions stationed all over the hospital to help people figure out how to click this and click that. And I think we should be doing the same thing for clinical AI systems because they do represent big changes to the workflow. And so we should be supporting our clinicians by making those integrations as gentle and as comfortable as possible so they really can benefit from the information that's in there and they don't feel like we're just attacking them with more BPAs that they have to click through to do the work that they're trying to do.
Fantastic. Well, we're right at the hour. Thank you again, Dr. Weissman. Do you want to get the last word or is any other parting thoughts? And where do you think the future's going now? You did a really great survey of a lot of approaches and thinking, advances in computational algorithm thinking and how they apply in different clinical settings. What do you think is happening next, or what are you looking forward to?
That's a good question. I guess my closing comment, especially for the trainees in the room, is think broadly and think creatively. There's a tremendous amount of hype right now about clinical AI systems, in part because there are large financial incentives to do them, but the amount of evidence we have that they work well relative to the number of published papers is still very small. So this is not a solved problem. So I encourage you to think broadly, creatively, in a multidisciplinary way to really try and do this well and keep patient well-being at the center. So maybe I'll leave with that. Yeah, it was great chatting with you all. Thank you so much for having me, and feel free to email me or connect on Twitter or whatever else to be in touch.
All right, fantastic. Thank you, Dr. Weissman.
Thank you.